everyone. My name is Erica Bro. I am the Key Account Manager for Atlantic Provinces. I have the delight to present to you the next speaker. Emily is a certified NSWOC, so nurse specialized in wound ostomy and continence at the IWII Health here in Halifax. She graduated with a Bachelor in Nursing from Dalhousie University in 2010. After spending the majority of her career in a very busy pediatric surgical unit, she completed her ET nurse education program. In 2018, Emily accepted the position of the nurse specialized in NSWOC at the IWII, working with patients in all three subspecialties, ranging in age from extremely premature to elderly. And she is also responsible for the program for NSWOC at the pediatric community of practice. So please warm welcome, Emily.
That's so nice. So I'm Emily. I work at the IWII here in Halifax. So I work with mostly pediatrics, but I was left one day. I went from a 20-weeker to a 99-year-old elderly lady on the gynae floor. So we do women's surgery and obstetrics, so family newborn. So I see C-sections and adults. I get the pleasure of not having diabetic foot ulcers and leg ulcers, but I have other things that are tinier too. So that's me. So I'm going to talk a little bit about wound cleansing today. My first question, and there was supposed to be a little word cloud, but it's not working here. So I'd like you to just kind of shout out what prevents you from cleansing a wound properly in your practice. I'll say one, pain. Time. I'm worried about causing pain. Time is huge, right? Are you worried about taking too much time, someone being upset with you? What about supplies? Do you have the correct supplies all the time? Things like that. So here, I don't have the time. That's the number one. If I take the time, people are going to get ticked off at me because they're waiting for me to go to break till I do this wound dressing, so I can't take that much time, right? I don't have what I need to do it. And pain is huge. So the common myth is that this is wound cleansing. So how many of us have taken the pre-done saline syringes, just squirted that over a wound, right? Pouring some saline over the top, is that actually getting rid of things? Those little ampules with 2 mils in them, is that cleaning a wound? Are you doing much doing that? So this is not wound cleansing. If you have a wound that looks like this, and you take one of those 2 mil ampules, you're not doing much, right? So to cleanse a wound, you actually want it to be clean at the end. And that's something that we've really kind of failed, and it's a gap in our practice. If you are not cleaning a wound and preparing to put the adequate dressing on top, failing to prepare is preparing to fail. You're going to have lost wound healing, right? So NSWOC with the IWII did a survey of all NSWOCs in Canada. So this is some of the results from that survey. So 95% of NSWOCs said they commonly use saline in their practice. I was one of those. I commonly use saline in my cleansing practice. Almost 80% agree that all chronic wounds that have been there for a while are contaminated or infected. Microorganisms grow where they eat and grow, right? They're there. On average, NSWOCs have 4 cleansers that they choose between, depending on what the wound looks like. But there's 1.5 NSWOCs, so nurses specialized in wound ostomy and continence, per 100,000 in our population. So we're not seeing all of those wounds. There's a lot being seen by everyone in practice and continuing care and long-term care that don't get seen by us. So also from this survey, 91% say they always clean wounds. I'd like to think we were a little bit higher than that, but also there's sometimes when someone's in a lot of pain, or you have someone who is at end of life and you're not doing things that cause pain or discomfort. So there are those patients that probably fall into that 9%. Okay. I already said on average, we choose between 4 cleansers. The top cleansers on that list, 95% go for saline, 58% go for hypochlorous acid, which is great. And that's what I'm talking about today. We NSWOCs also get visited from our reps a lot. And so we have the information on it. So it's probably a little bit higher than what you would see in an average kind of practice for an RN. or LPN or continuing care where we were. And then soap and water was at 34%, which kind of surprised me, but I've seen it used. So top reasons for when to pick a cleanser would be if there's an infection, you want something that's gonna fight the infection, right? Availability, what's on the shelf that you can go and pick from, and based on evidence. Which is interesting because we know, we're saying 80% of us agree that chronic wounds have infection. So the prevalence, like choosing it for infection is important, but we don't always do that. And then the techniques that were used in this survey, 60% say they did irrigation. And I find this really interesting, and I went and looked it up because in order to irrigate a wound properly, you need 100 mils of saline with the appropriate pressure. So a 60 mil syringe with a 18 gauge catheter on it. You need 100 mils of saline per centimeter of wound. So if you have a 10 centimeter wound, how many people would irrigate properly with the proper pressure with 1,000 mils of saline? Anybody? I wouldn't. I might take a 500 mil bottle and pour it into a big open wound to kind of irrigate things out, but not with the correct pressure. So are we actually irrigating? Not really, right? And then soaking, so 37% of people said they were soaking, and they were doing this in the presence of a biofilm or with a lot of slough, and that tended to be with the hypochlorous acid. So what we're trying to do is empower nurses to standardize the care and fill that gap in care. So we know effective wound cleansing is important. We know getting rid of bacteria and not causing harm, so not causing the cytotoxicity is really important. We don't want to kill the good cells, right? Many people use saline, but we also use some of those traditional solutions like Dakin's or hydrogen peroxide. And I will not name names, but I still have a surgeon who swears if you pour peroxide in that slough, until the next time you open it up and there's more slough because you killed all the good tissue. But they want to get rid of that slough and that bacteria. And that integrating solutions that kill bacteria without killing the good tissue is probably a good idea. But there's a gap. We know this. This is logical. This is common sense. We want to kill the bacteria without killing the good tissue and have clean, healthy wounds, but we're not doing it. It's not happening in practice. And wounds are kind of that final thing. We have our line policies, we have our event policies, we have the surgical site infection packages, but wounds, we're still dripping some saline in there, dabbing it off, and putting a dressing on, right? We're not cleaning them properly. For optimal wound care, you really need that environment that's clean. So why do we need to clean it? We need to get rid of that tissue in there that's bacteria food. We don't want to feed the bacteria, we want to get rid of that. We want to make sure the wound bed is healthy so that when you put that dressing on, whatever dressing it might be, it's ready to help create that warm, moist, clean wound environment and promote healing. Wound hygiene has been a big hot topic for a little while. I hope everyone has heard the term wound hygiene. If you haven't, it's cleansing, debridement, refashioning, and anti-biofilm. So cleansing is the number one step. That's the most important. And getting rid of the biofilm is also really important. So this is one way we can kind of set out to do both of those things. So the International Wound Infection Institute put out these recommendations based on surveys and tons of research done by people who are much smarter than me, that all wounds, wound edges and peri-wound, which is something that I found really intriguing, something that's not talked about a lot, should be therapeutically cleansed. So we're throwing out the term therapeutic cleansing as sort of the new hot topic for this year. And therapeutic cleansing is the active removal of surface contaminants, loose debris, non-attached, non-viable tissue, and remnants of previous dressings from the wound and peri-wound. Erica already said, I went to school in 2010, and that wasn't that long ago. And we were still taught to take your forceps and your wet gauze, you go down the middle of the wound, and then one swipe on the outside and one swipe on the other side. Anybody else? Yeah, so you move the bacteria around. You definitely didn't get rid of it, right? So The IWII recommends that all wounds, including the edges and the peri-wound. So if you think about all those bacteria that are hanging out, if any drainage gets out on that peri-wound skin, if that's not cleaned off, that's just crawling into the wound under the dressing. So you have to make sure that all of that is clean as well. So wounds should be cleansed with an inert solution at every dressing change. And then this is something that I teach and I thought was really cool when I started doing this presentation. In any of my education, I had this slide. I don't think there's anybody from the IWK, they would have seen it. I have this slide that goes up and says, if you're gonna swab a wound, do you clean first or not clean first? Put your hands up if you clean first. Put your hands up if you don't clean first and you're swabbing that pus. Oh, good answer. If you're swabbing pus, that's bacteria food, that's where they live, that's where they eat. They're happy there, you're gonna swab, you're gonna get a positive result. Every single time, you need to clean your wound and swab from a viable piece of tissue if you wanna know if there's actually an infection. That's my little input there. Effective cleansing disrupts the biofilm, so water or saline cannot disrupt the biofilm. It gets your wound ready for debridement. So that's the second step, right? In your wound hygiene is debridement. Some of this actually debrides as you're cleansing and soaking. A lot of the tissue will actually debride itself, but it also cleans and gets ready to do, if you need to do mechanical debridement or sharp debridement, it gets ready for that. We know chronic wounds exude harmful enzymes like MMPs that keeps everything in inflammatory, and it can degrade the peri-wound. So we need to get rid of that so it's not degrading the peri-wound skin. The fluorescence imaging is really interesting, and I have it on the next slide, so I won't, but it shows that the bacterial load goes down when you use an antiseptic solution. And then cleanse with each dressing change. So there's a lot of talk about frequency of dressing changes, frequency of cleansing. My rule of thumb is clean when you change the dressing. Every time you change that dressing, whether it's a 7-day dressing, a 1-day dressing, a 3-day dressing, you're cleansing at that time in between dressing changes. So talking about non-antiseptic, so your saline, soap, water versus antiseptic, that's common sense, right? The ones that kill bacteria are gonna kill more bacteria. So if you look at the fluorescence here, this is before cleansing, and it's imaging that shows bacteria glow. So you can see how much more glow, and I find it really interesting. Look at the peri-wound, all the glowing. And then here, you're seeing much less. It's kind of all concentrated where that probably eschar is stuck to the wound. But there's no statistical significant difference between antiseptic cleansers. They all kill bacteria. So how do you choose which one you're gonna use? Well, the tiebreaker is it gonna kill the good bacteria? Is it gonna help you debride that bacteria food off the wound? And is it gonna keep the pH of the skin? And I'll talk a little bit more about pH in a second. Some of the considerations you should think about when you're choosing is, what's the patient's state? How are you gonna do this dressing change? Could they just jump in the shower and clean everything off if they're that well? Great, do that. If you need to do really sterile technique, it's post-surgical. How are you doing it? So what are you choosing based on how you're doing your dressing change? What does the wound look like? Is there infection or a risk of infection? How many organisms? How bad does it smell when you walk in the room? How much cleansing do you really need to do? Making sure that you're taking care of those other tissues, and if there's any allergies, making sure that pH, and again, I'll talk about that more in a second. And what's the goals of care? And I think that's also really important to think about whether your patient is in a mode for healing, or if we're in maintenance, or maybe we're just doing comfort care and basing our choice on that. And then your policies and what's available to you. And we all know that's probably one of the biggest factors. What's on the shelf, what's available in your health center. So the new recommendations, so clean all the wounds. Therapeutically clean all the wounds. Therapeutically clean that peri-wound and the wound edges with it. Clean with every dressing change, and also before you do swab or culture or biopsy. That's really important because otherwise you're gonna get that false positive every time. Pick which technique you're gonna use and then conduct a risk assessment on the patient. So have a look at what they're doing, how we can clean them. If they could maybe, I think the next one's get in the shower. Oh, use your universal precautions. There's the point. So maybe they could get up and get cleaned up, which is great, instead of laying in a bed in their bacteria. Selecting your wound cleansing solution. This is the same considerations I just read. I'm not going to read all those again. Using something that has antimicrobial properties if you think there's microbes in there, which a lot of times there is. And then don't use a microwave to heat. I feel like that's basic, but I still see it done a lot. The wound care solution that we're talking about today can actually go in a warmer for up to a week. So I'll talk a little bit more about my practice, but I do leave a couple bottles in the warmer, just so that I have warm solution if I need it. Make sure you're using something that's close to the pH of the skin. Use your wound technique. So have a look at assess your patient, assess the situation, and use the wound care technique that's best suited to that patient. Cleanse the surrounding skin. So you should start with that peri-wound and surrounding skin first. Get rid of any microbes that might fall into the wound. And then you're going to start in the center of the wound or the most vulnerable part and work your way out to get rid of those bacteria. And adjust your techniques for pain. We have to be careful. We don't want to cause a lot of pain. So I said I was going to go back to pH. The normal pH of the skin is 4 to 6. You want a solution that's going to keep the pH of the skin in that same general area. Vulnerable skin is more alkalinic. We know that a lot of soaps and a lot of our other solutions are alkalinic, and that leads to penetration of bacteria. That leads to the skin losing its natural barrier and letting things affect it more. So even in the peri-wound, but in the wound itself, we want to keep it at the natural pH of the skin. I'm not going to read this whole list. You can read this. I am going to talk quickly about skin grafts because burns are part of my practice, and that's my baby. And whenever you take off a dressing after you've had a skin graft, does anybody else work with burns or with skin grafts? You know, when you take it off and the whole thing melts off, it's the most disheartening thing. And I don't want to put out adults, but when it's on a small child that you know you're going to have to graft again because you've lost that skin graft, it is the worst feeling. You start to peel in and it just oozes out. It's not a good feeling. So keeping that pH, keeping it clean, keeping the bacteria out is so important for all of these things. But I take a lot of pride in our skin grafts and keeping them intact. This I found super interesting. So if you look at the columns, you have safety. So that's cytotoxicity, not killing the good tissues. Efficacy, does it kill bacteria? pH of the skin, so staying in that pH to keep it healthy. And then is it recommended by this IWII guideline? So you look at Dakin's, not safe. It's effective, but otherwise not okay. Salaine's safe. It's pH of the skin, but it doesn't kill anything, especially not if you're not doing proper irrigation, which no one in here was, right? Nobody? Chlorhexidine, same as Dakin's, acetic acid, PMHB, they're all the same, right? They're effective, but they're not safe and they don't protect those tissues. This is all supported by these high levels of evidence where there's a gap in practice. What we know and what we do are completely different, right? We know it's not rocket science that an antimicrobial is good to kill bacteria, but we're not using it. There's limited evidence that saline can get rid of bacteria. Again, we're not even doing it properly, so it probably isn't getting rid of that bacteria. Using a cleanser to get rid of microbes, probably a good idea when we're trying to get that wound to heal. Ideal cleansing should remove microbes without damaging the good tissue, causing more slough in the wound. And then traditional cleansers like peroxide, hypochlorite, and hypochlorous acid that we're talking about and hypochlorite. If you want to know the molecule chemistry, you'll have to talk to Benoit back there because he's probably smarter than me. But they're different molecules and they work differently. So if you hear that, they're not the same. Iodine, they're all cytotoxic and cause harm to those good cells. So that's in the evidence. That's high level research evidence. Pure hypochlorous acid, safe, effective, is in that right pH level, and it's recommended by these guidelines. So that's what we're talking about today, is that pure hypochlorous acid. And it also can help to amplify other debridement techniques. So you use it, it starts to debride, and then other debridement techniques work better once you've used that. And I've seen that time and time again in my practice, where the debridement actually comes along much better after I've used the hypochlorous acid. So this is all the microorganisms. And I'm just gonna address this question right off the bat. Maybe it'll save you some time later, Erica. Because I remember asking, well, if it's 15 seconds to kill all those, why am I soaking for 5 to 10 minutes? That's the question that I asked. First thing, wasn't it? Right off the bat. It takes 5 to 10 minutes for that solution to get down and surround all of those microorganisms, or most of them, where 15 seconds would only get the ones on the surface. So that's why you want to soak. So in my practice, I soak a saline or soak a gauze, or I'll pour it into the wound if it's a big wound, lay it on while I'm getting my tray ready. So it has time to sit and work for 5 to 10 minutes. And then I remove that, just dry around the edges. You don't have to wash it out or remove it. It turns into saline after 15 to 20 minutes. So it doesn't have to be washed out of the wound. We know it can disrupt colonies, and there's no known resistance or relevant resistance at this time to any of these microbes. Safe for everywhere. So the first question I always ask the pediatric nurse is, can I use it on my babies? Can I use it in NICU? This is safe for everybody. Safe if it gets in the eyes, safe if it gets in the mouth. If they take that gauze and start sucking on it, I'm not worried that they're being harmed. In some studies, it's shown to be used in mouth, like oral wounds. So it's safe for everywhere and everything. We don't have to worry about it. Again, it turns to saline after a little while. It's not harmful. We produce it naturally in our body. And you can see the cell survival of those fibroblasts and keratinocytes is greater than 75%, so it passes. Along with saline, all those other solutions are going to fail because they're killing those cells. And those are the ones that are important for wound healing. So the number one thing, like you can walk down the street, any street in New York, and see the number one coffee house, the number one pizza house, the number one bagels. That's not, so for me, that's company mumbo jumbo. What was really important to me is the peer-reviewed publications, all the data that's out there about how effective this is, how it works, the safety. That was what was really important to me and what drew me to hypochlorous acid in the first place. So I'm going to talk a little bit about my practice. Hopefully, how am I doing for time? Yep, good. So I'm going to talk a little bit about my practice and how I use it. And then I'm open to any questions if anybody has any. These are just some places that VASH can be used. Venous leg ulcers and diabetic foot ulcers. Like I said, I don't have a lot of that in my practice, but I'm sure most of you do if you work not in pediatrics. I use it a lot for IAD and burns, and I'm just going to flip and talk a little bit about that. So these are my, when I was asked to do this presentation, I thought, okay, cool, I'm going to start taking pictures. And then I just didn't have any great before and after pictures. So I thought I'll go through and show you the ones that I use VASH on, hypochlorous acid, and how I use it. I don't have any great before and afters, but these are the ones that I would use it on. So my burns, on my burn cart that I actually have stopped stocking VASH for the most part, or saline for the most part, and only have hypochlorous acid on my cart. I do warm it if it's a big burn like this guy, I would have warmed it for him. But I wrap everything when I'm getting my tray ready. I wrap everything in hypochlorous acid before I start. So about 5 minutes soak for everybody. Surgical wounds. The one on the far there is an abdominal wound. I know you can't see it too well, but there's a tunnel. And I will actually take a syringe and a IV catheter and just not inject, but use the catheter to get it right down to the bottom of the tunnel. I find pouring, I just can't get it to the bottom. It sort of bubbles, but I will make sure it's right down to the bottom and then put a nice wet soaked one over the top for the peri-wound, get my tray ready, and then go back and just dry everything up and put my dressing on. The middle is a little NICU baby. And this picture is not great, and I apologize, but she had a transabdominal incision that split open in between all of the interrupted sutures, and she had slough, and it just was kind of gross. But we really didn't want all of that to get infected. She was having a hard time anyway. So we would soak her every 2 days and do the dressing change. And it was completely safe for her in NICU. I think she was 31 weeks at that point. I could be wrong, but around that. So we do use it. And then pilonidals, like this is my favorite place to use it. So sorry about the butthole picture first thing in the morning, but that's what I deal with. So you should. If anyone does pilonidals, you know they always get that like maceration and irritation around the edge. from the drainage. It's such a hard place to keep clean and dry. And it just works so nicely to clean that and get down to the bottom of those wounds and get them clean. Traumatic wounds, or I should have worn, like, I hope everybody's good with pictures as you have your breakfast. Always with traumatic wounds, when you don't know what kind of debris is in there. So the far one was just I think he was a dirt bike accident that got closed and there was some debris in there. So we would soak with every dressing change. This was a guy that had compartment syndrome that we actually used it, the indwell and instill indwell negative pressure. So we used Bosch with that. And I actually got in trouble with my plastic surgeon because if you can see here, this nice healthy granulation tissue, well, he was planning to close it and he got mad because I made too much healthy granulation tissue and he was gonna have to cut it out. So nice and clean, right? Nice and clean. He had a lot of muscle and tendon depth. So a lot of slough and debris that had to come out of there. And it did great to clean that out and make the granulation tissue grow too much, apparently. Like we could just heal it this way if you want to do surgery. One of the biggest places that I use it in my pediatric practice is with diaper dermatitis or incontinence associated dermatitis around tubes on bums. It's great to rebalance that pH. If you think about the stool and the urine, changing that pH on the bums. So I wet gauze, I lay it on while I'm doing something else, take it off, let it air dry, don't wash it off, and then put on the creams or whatever we're using for care. And usually it helps to heal it up very quickly. I wish I had more pictures of sort of before and after because this has been a game changer for us in our diaper dermatitis population. And then around tubes, when they get same thing, the stomach acid coming out. The one on the far side is a cecostomy tube. People probably aren't super familiar, but that's a poop tube that goes into the colon and stool sometimes leaks around and can cause a real mess. So we use it there to rebalance the skin. And then our others, anybody with hardware sticking out that the ortho surgeons always think that it's gonna grow over and it never does, but trying to keep it from getting infected all the way around the hardware. We know anything exposed is colonized, so that was really important. This guy had a back or a negative pressure, I think it was a back on, and we would use the hypochlorous in between changes. This is a phalloceal in the middle. Yes, that's her small intestine and liver in there. And it was so huge for her because it would smell. And we would be changing every 3 days and it would have a lot of smell. So I brought up my hypochlorous acid for cleansing in between and the smell went away. And we would leave that on instead of, we always did saline soap to keep it moist. So we would do hypochlorous acid soap, which we know turns into saline, but it kept the smell away. And that was so huge for her parents and holding her and caring for her. And then this is just another, same idea, long farther down the road. So on a phalloceal that had healed, but a lot of slough there. So I used it to kind of clean that slough off. That might be the end of my, so these are the guidelines. That's the QR code if you want to download those guidelines. That's the end of my little rant on cleaning wounds. Are there any questions?
Yeah.
Is this new information for anybody? I know I was practicing in my office with some of my colleagues and they're like, why haven't you told us about this? We should be using it here and here. And I'm like, it's the blue bottle. Oh, okay. So yeah, it's huge in my practice.
It sounds like quite expensive, or is it more affordable?
Not that expensive, especially when you think about how much saline you should be using to clean a wound. It actually works almost the same if you were using proper amount of saline to irrigate a wound as you would the wash. And it comes in a bottle, you don't need as much, right? You only need enough to soak your sponge. 20 to 30 cc's for a 4x4 gauze. You would be using a lot more saline, so it does work out. That's how I sold it to my manager because it works out to about the same. So
So.
You irrigate with saline before doing the dash, so directly there.
No, I use the Bosch right off the get-go. I don't irrigate with saline.
Even if there's water.
No, I soak it first and then I'll
Nothing misses off.
clean it out that way.
You miss
If there's
her?
stuff I need to kind of wash out afterwards, I might use saline just to push it out. But I always soak first before I do anything else.
Lee, are you saying not to irrigate at all, just for the soap?
Well, if you need to irrigate, like if you need to wash it out, I do. I usually have to say I usually use it when I'm irrigating, but I always soak first.
You soap and then you irrigate.
Soak first to see if I can loosen up that any of that debris.
Okay.
And then if I need a big irrigation afterwards, I will use saline just to kind of push it out, so I'm not using a whole bottle. But for the most part, honestly, I'm putting it in, I'm soaking, and then I will just either use the wall suction and suck it out of the big wound. I don't know if that's proper technique or not, or I'll just kind of use mechanical cleansing.
Yeah. Thanks.
Yes.
I work in a clinic where we do a lot of pilot care. Would you say, because we do a lot of like saline soap packing, so where it turns into saline, could you essentially like clean with it, and then when you're doing your packing, could you soak it in it?
You can, yeah, if that's your practice.
Okay.
I feel like there's a lot of better options
Okay.
but that's a whole other story. But yes, I would absolutely use hypochlorous as my like saline, yeah. Yeah.
What would your recommendation be with safe breath? Like this cleansing and.
Let's get, just with dressing changes, I soak while I'm getting ready. It's kind of the same for everybody. I soak it while I'm getting my tray ready for any wound. And then do the dressing change as I normally would.